My name is Umesh Prabhu, Medical Director I was Medical Director of Ridington, Wigan and Lee, reduced harm by 90%. Yesterday I gave a presentation how we did it. And I personally feel Joe's point is absolutely right. Until we get the cultural changes right, whatever digital investment you do, you are not going to see any differences because there's a strong demanders culture in NHS. I think culture is where we focused and staff engagement is where we focused and put robust governance, reduced harm by 90%. The second thing, I'm now doing some work in India, and India has got fantastic IT, which is much, much cheaper, and NHS can be transformed with some of the digital things which I've seen in India. I think unless we focus on culture, unless we focus on values, good governance and leadership, I think we are not going to change much in NHS.
Okay, so good comment. There wasn't a question, so I'll move on to one of these hands up, please. Next microphone. Thank you. Can the next person that wants put the hand up so we've got the microphone there?
Sheffield, my question is about what we think the role of NHS Digital should be. For example, in terms of the systems that are being supplied to the NHS, is there a role for NHS Digital in putting pressure on some of these companies to improve the functionality and performance, for example? And Professor Severs, at the start of this morning, extolled the virtues of GP-structured records. Is there a role for NHS Digital in mandating that hospital records are also structured in a similar way?
Keith, would you want to take that one, please?
Yeah, what do I think the role of NHS Digital is? Yes, that's part of its role, but it's part of the whole system's role is to advocate for functionality within those system suppliers. I would agree with you entirely, and in fact we are working with them to do just that. It's not just NHS Digital's role though. NHS Digital has a very wide role in terms of providing services that enable us to do our work every day, as well as looking into the future at what new technologies we can bring to bear in concert with the rest of the things that are going on around the system in IT. And structured health records in acute settings, absolutely, and a bit further behind than in general practice, but that is definitely coming. Okay. Why aren't they now? Well, it's been a cacophony of people going off doing different things with different levels of maturity. It really is hurting squirrels in terms of getting people to do what they need to be done. You can't. We learnt from Connecting for Health that you can't dictate things from the centre. It doesn't work. So we've got to galvanise the coalition of the willing from the ground up and get people to buy into this. And in fact, that's happening with Interopen, with PRSB and the standard setting that's going on there, which is being driven up from the ground. And we need people engaged in that process. We've learnt from bitter experience that top-down implementations and mandating things just doesn't work in the NHS. It's too big.
Ian?
Yeah. To both of the question and the point, that I think there are three principal components here of digital transformation. You've got culture, technology and management. Yeah. The technology is the easiest bit of that. But alongside technical standards being issued and encouraged by NHS Digital, I think expectations of what might be done at the front line could also influence the hardest part of those three, which is culture change. For example, patient involvement in digital transformation initiatives. Just down the road here, we have novel forms of feedback, real-time medication safety surveillance that happens with advanced algorithms, and we involve patients in what happens with the data. So the data travel to an advanced analytics lab, identifying drug-drug interactions, drug diagnosis interactions, things that might be done better. The patient said, if the GP receives a notification that that prescription might need another look, can we receive a text message at the same time? Now, NHS Digital is doing some very good work in looking at that new patient booking and the app being the front door to your general practice in transactional terms. Bringing those two together where there's a strong patient voice in innovation with a technology direction which requires clear, consistent standards, I think will help with the culture change.
Thank you. Next question. Has everybody got a mic? Yep, off you go, sir. And there's a lady down the front who wants to ask a question as well for the second mic. Thank you very much.
Hello, Dr. Jayadkar. I'm a GP, also work for the CCG exec, work as a CCG exec in Westlang CCG. I've seen a lot of use of technologies. We've had someone from your department who came to our CCG, and a lot of gadgets that we saw which really would help us work much better than what we do. I, as a clinician, see a huge problem which I think we need to, or NHS digital needs to look at first, and I think some of the points were made. Different GPs use different systems, hospitals use different systems. We've get inundated with letters asking for information or a copy of a CT or MRI scan from a different hospital. So the whole system needs looking at, and rather than everyone making their own decision regarding the systems, we need to have a single system where information, whosoever puts it in the system, can be used and can be, and it'll really, it's very frustrating for me as a GP, not getting the information. The discharge letter takes 2 weeks, and when it comes, there are kind of, so we talk about a lot of technologies, but I think there is a basic problem that we need to fix first.
Okay.
Then definitely the technology could help us work even more effectively.
Right. Okay. So let's take that as two challenges. One is a business change challenge about secondary care clinicians not getting the communications to you, but the fundamental one was common standards versus common system. Maureen.
Yeah. Well, I totally recognise the scenario, the painting you've just set out, and it's hugely frustrating. Why is it that the NHS is the only organisation in the world, I think, that still uses faxes? Why is that? It seems to me that the one system isn't going to happen. The NHS has been down that road before. It didn't work. I don't see that happening in the future. So the key has got to be about standards for interoperability, standards for safety, standards for information governance. So it's about, I believe, we as a collective group of clinicians, through the faculty, through NHS Digital, through the Royal Colleges, agreeing what standards we need to make this operation work for everyone, and then getting everybody behind that, and then, like with the previous question, then ensuring that the suppliers comply to those standards.
Joe, you're at the front end, the hard end, as particularly in a service which is under a lot of strain. Your views on this?
Yeah, I mean, there isn't anybody in the room doesn't recognise the problem. I would say. We're all frustrated to death by this, actually, and there's a sort of paralysis in place around what we do next. There's a something here about, I think, if we think about the opportunity, we keep focusing a lot of the time on what we can do to enable the next piece of change. And I think what we don't think about is how can we also use some of this technology to relieve the burden, if I can use that phrase? And you used the phrase, I think, get the basics right. And I think the danger is that we forget we're towing a caravan here. And we've got to make sure that we really make that a strong part of the focus on this. And I guess the last point would be, Martin, I was struck by your comment this morning around the potential to do unsafe things, just by accident in a way, possibly. And I wonder, in all of this stuff that goes on, how many people are unsafe because we can't join the bits up. Yeah. And maybe that's the place we should be getting into this conversation, is about how do we make it safe, rather than how do we use all the opportunities to create yet more sort of noise in the system.
Thank you. Lady down the front, and then the gentleman here in the white shirt, and then we'll move to you, sir.
Hi there, it's Anne Cooper, the Chief Nurse at NHS Digital. My question is about what you might have as your top tips about how we engage the wider workforce in the agenda that we're all facing, because it can't be delivered by a select group of leaders, it's got to be delivered by everybody. So how might we go about that?
So, Jane, I think that one's for you.
Okay. I think you've sort of hit the nail on the head, really. And I was talking, after my talk this morning, I met somebody from a trust in London who said that actually I'm trying to engage the wider workforce, and particularly the nursing workforce, and they keep saying, what's it got to do with me? I'm a nurse. And you just that sort of misses the point. So I think for me as a clinical leader, and for everybody in the room who are clinical leaders, this is about showing the art of the possible, I think, and really demonstrating the impact on patient care, and patient outcomes, and that will include, as Joe's just and Maureen just referred to, around safety. So I think it's shifting hearts and minds away from the it's too difficult and I don't understand it, so I'm not going to do it, to actually I can do it, I can understand it, and look at the impact it has. And if we can do more of that, and we can really demonstrate the impact that that has in terms of the environment in which people work and the outcomes for patients, it will drive change at an individual clinician level.
Can I just come in and be a bit more controversial? I'm going to ask David, and I'll go to Ian. You asked about changing in the workforce. Nobody asked me to become an airport worker or a bank worker, but I had to take on the responsibility of looking after my own money digitally after booking my suitcase in. So I think we're missing a trick by thinking about workforce. So I want to ask David to take your question one step further. Are we missing a trick that the real workforce that we're missing is patients?
Absolutely.
Yeah, good point.
And for the last 30 years, I've been involved in projects to do with social informatics. And they've involved education, healthcare. And the big issue for me is the flip from supply-side thinking to demand-side thinking. And it really is as simple as that. Once you start to make that a part of the way you plan a service, a colleague of mine refers to NHS as an industrial age service. It's one in which a supply is provided for a patient body. And it's quite old thinking in the way it's evolved, because a lot of the systems now are about how you empower the individual to take better service, to manage their own healthcare issues. But of course, healthcare is something that's ephemeral. It comes along, it's an issue for a while until you or your family sort out that problem. You've got finance issues, you've got maybe relationships issues, and you need an information system, which is the very thing that we're working on at the moment, which is a future societies platform, which enables the individual to take better advantage of all the services provided.
Yes, thank you. Ian, final point on this one.
And the more connected we are with digital technologies, the more we see each other's actions, the more we have the opportunity to create a new supply chain of better value healthcare. But supply chain for what? For an organization, for an infrastructure? That's not the end point. The better value is. We could identify many items in which we want to transform current activities to be more joined up across a whole health system, employing the wider workforce in a concert of action. But boiling the ocean won't get us forward. I'm enthused by what I see in the Connected Health Cities project across North England, where the teams were asked to focus just pick 2 care pathways per region and think about all of the actors, the most important being the patient, on those care pathways and optimize those. What are the disconnects at the moment in current healthcare that you have as priorities to connect between organizations, between patients, practitioners, and different sources of data that currently operate in islands?
Thank you. Gentleman with a mic. Yes, thank you.
Thank you. So I'm a pharmacist, clinical informatics by background as well. So I just wanted to understand what the panel's thoughts are about the dissemination of lessons learnt within secondary care, potentially for electronic systems. Because currently there is, within the NHS, different acute care settings have different levels of maturity. Some are in the midst of procuring, some in the midst of implementing, some in the midst of actually business as usual. And I was just having a conversation with my colleague to the right, saying that we seem to be making the same mistakes, and the suppliers seem to be taking advantage of those mistakes on each and every occasion. My old chief medical informatics officer is in Virginia, he's in Pennsylvania now, and he's leading on Geisinger, where they have a 50-odd hospitals. So granted, yeah, if there are issues that are occurring from system levels, you can start them from the ground up. But the challenges that you face are you're a lone voice within the NHS. So there needs to be some sort of coordination to say, well, these are the problems that we're facing in so many hospitals. With these systems, how can they be overcome?
Thank you. So, question about two things. One where something's happened, you understand the lessons, how do you get that out? Second thing that you addressed, as far as I heard it, was you don't know what to do and you need some help. And both are as applied. So let me start with Keith, because NHS England is doing some great things with digital exemplars.
Yeah, so a common problem, of course, is how do we share learning across the NHS if you take it at that level. That is a big problem. It's not only in technology and systems, but in clinical safety, in how we set up organisations, etc., etc. So it's been a problem for big health organisations right across the world. National Information Board is taking that on as a challenge and setting up a learning from local scenario where we're going to take system-wide leadership to actually find where all the good stuff is happening and disseminate it and make sure we get it out to people. Will that work? I don't know, but it's going to be a consolidated attempt driven from the ground up to do that. We are, as part of the 2020 program, the National Information Board 2020 program, we have stood up what are called digital exemplars, of which Joe is one of them, where we are looking to consolidate learning from organisations that have done the hard yards, that have been out there, done the right things. We're looking at to leverage buying power on vendors so that we can influence them in the way they act towards us. We want to use blueprints from those organisations so that people don't have to relearn every time they go to set it out. Use the 80-20 rule, 80% of it's going to be common across. And we will see that spread out and out and out. So we've got the GDE's announced the 16 acutes, the 7 mental health. Very soon you'll hear about the next fast follower cohort and then the next cohort after that. So that's the attempt that we are making to do, as you say, which is not reinvent the wheel, use best practice and disseminate it as widely as we can. Key word in that was learning, and the shadow chair of the faculty.
Yeah, I'm the shadow. Chair.
I'm sorry. Maureen. This is a bit of bluff. Whilst Maureen thinks, how the heck do I answer that question from a learning perspective? Off you go, Maureen.
No. Listening to the question, it strikes me that actually this is what professional organisations are about. You know, coming together. I've got this problem. What did you do? How did we learn? And that we haven't had this professional forum before for clinicians who are informaticians. So one role I definitely see for the faculty is this bringing together, sharing, supporting each other, acting as a peer group, having learning sets. We will learn from each other.
Okay. Ian.
The disruptive clinical informatician. People in this room and those on training paths to really create, compare, contrast, competition between different vendors. What do you really want for your health system? That doesn't mean a choice between different vendors, but you start to force mix and match functionality. You really bring those requirements into a disruptive setting as a collective force of clinical informatics. Last year, I had the great delight of spending time with some of the new graduates of subspecialty training. So clinicians who had taken board exams in the US to become a subspecialist in informatics and work as part of their time as a group who can truly disrupt the vendors in current providers. We must invest much more in those disruptive clinical informaticians, but not to work individually, to work as a force for the NHS so that it has its collective pressure on driving better technologies that we really need to serve our health systems.
So, Joe, I want you to finish on this one. You've got the real-life issues of trying to share.
Yeah, and I think what people have said here is absolutely right. Just as you were saying it, however, I was reflecting on the fact that we all know there's a huge variation across the piece in the systems that we use, and we've all tolerated that variation, that explosion in variation. We also know that, and I think Jane alluded to it this morning, big variations across almost any clinical pathway you can choose to encounter. And the question is, why do we tolerate that variation? And I think that's the question about, it's really, really difficult in the NHS to develop a learning system. We've thought very hard about this in our organisation. How do you learn? It goes back to Umesh's point, which is ahead of that. If clinicians feel that if something goes wrong, they're going to get blamed, then actually they stop learning.
Yeah.
And we've got to really take that, and I'm really keen as part of our digital exemplar that we're going to get inside and tackle that sort of stuff. Because we don't do that, I think we stop in our tracks.
So I will take an action with Raj to think about how we use, if we can persuade people that we need to do this more, how we do learning, of how we do, what sort of innovative way we can do it next time. The other thing about learning that Joe's point was, as Hugo Massey-Taylor did the mid-staffs and inquiry. It was the first time we've had a clinical administrator, and I was talking to him. I said, what did you feel? He said, it was really interesting. I felt uneasy, and I walked around the hospital 2 or 3 times, and I couldn't work out why I was uneasy, and then I realised there was no learning. So Joe's point about learning, if we stop learning, we're really in trouble. So Karen at the front, you're next.
Thank you. My name's Karen Swinscoe. I'm a senior clinical leader at NHS Digital and a nurse by background. I think my question might be slightly rhetorical, but I absolutely agree with the staff engagement, frontline staff engaged in information at the fingertips when they need it. But I guess my question is, as a leadership team, how do we protect staff for that to some extent as well? So how do they get permission to have a day off without things pinging in the Facebook or in their pocket? So it's using digital technology to advance patient care and the workforce, but I guess it's a plea really to make sure we protect the workforce so they're not always, you know, glued to the smartphone or feel they need to check on a patient at bedtime and do that first thing in the morning.
Thank you. So interesting one, and this, Wachter brought this up in his report, this about the 24-hour on-call clinician. Jane, I'm sorry.
It's all right. It's like 24-hour senior leaders.
Yes, I know.
You know. And we're all probably guilty of that. And I know I am. So I suppose there's something about us acting as role models and giving permission for people to not be glued to their iPhones or their, their emails, etc., whether you be a clinician or not. There is also something about, when I talked this morning about leading change, adding value, is there is a very clear piece of work, very clear evidence around supporting staff to feel enabled, able to speak up, all the things that Umesh and Joe and others have spoken about. So there is something about really living those values. And it's easy to say and quite difficult to do, but staff have to feel that they are listened to, that they're empowered, that they're able to make decisions, and they've got permission to speak up, but also permission to suggest new ways of doing things. And you have to do the "you said we did" type approach, and it's. I mean, you'll get a range. I would imagine a range of comments from us sitting here, but the only way that you can really show that is by evidence and by demonstrating it within your organisation, wherever that is. And it takes quite brave people sometimes to either take feedback from colleagues or staff to say you're wrong, and you just have to stop. So when I'm doing an email at midnight to some of my team, I just have to stop and do I need to send this now, or can I leave it in my draft folder and I'll send it in the morning at a more reasonable time? And I don't expect people to respond, and that has to be the way for clinicians as well. But you balance that with the fact that people actually sometimes do need to be available, and they do need to be available out of hours, and it is appropriate that they do when they're on call, and they do need to be available to go in and not just do that from home if it's clinically appropriate for them to be in the organisation, in the building, in the room with patients. So it's about values, it's about behaviour, and it's about creating that right culture for people to be able to feel safe to speak up and feel safe to make decisions that are that actually benefit them, but also, more importantly, benefit our patients.
Okay. Over there on the right-hand side. Thank you.
Hi, I'm Mitch Tomonaga. I'm a governing body of Warrington CCG and a GP. As we are doing more and more of the information and data sharing, seems to be that the emphasis is on sharing and there's less emphasis spent on what do we do with the information after. So in terms of sharing it with patients, there seems to be no agreed or thought on how the information will be displayed in the way patients can understand and make it useful. For us as clinicians, I get pages and pages of information from other organizations, not all of which would be helpful to me. And on the bigger population level data, if I ask the CCG managers how much of the analytical tool do they use in order to make a difference, they would answer very little, because one, they don't understand it, and two, they don't have the time or the workforce to be able to do it. So how do we tackle that problem of what do we do with shared information?
Okay, so it's about purpose. It's really about purpose. Well, we should have a clear purpose. So I'll start with the academic view. Ian, do you want to start, and then we'll have different views. All right, Ian.
Yeah, academic, but you need to be deliberately practical here to understand information behaviours.
Yeah.
I see the NHS sold a blizzard of useless dashboards that are reassuringly expensive, repurposed business intelligence, just giving you a summary of what you do badly and telling you, instead of telling you at the right place, at the right time, for the right patient, in the right way, what you can do better now. So actionable information, not just a summary of data built on what we used to do in the past. This is a really important principle of informatics, to take something that we currently do badly. Drug-drug interactions, all of those alerts in an alert-fatigued general practice consultation. Ridiculous to just inflate that. We need the high-priority information that suggests this is what you can do right now, and present that increasingly to the patient and clinician at the same time, so that there's a richer consultation the next time. We're treating that journey. We're pulling through more actionable information from more team-collected actors that see each other over data. And that needs focus, and I would suggest you champion some of those foci and then pull in the relevant bits and technical innovators.
Brilliant. So I'm going to ask David to come in a second. We've also got to think about patients doing things we've never dreamt about. So when I started to share all my letters with the patients, this guy came by and said, "Doc, you saved me 30 quid. I said, what do you mean I've saved you 30 quid? He said, that letter you give me, put me right over the housing list. I shared it with housing, well on there, really good. So patients can actually start to change. Now that was decreasing the load on GPs. So one of the things is, back to the learning point, we need to start learning from what patients do with their data and how what their requirements are, which wasn't, I wasn't meaning to be facetious about Anne's question about workforce. I think we need to start thinking about them. David?
I'm one of those fortunate people who has total access to their patient records. And there's probably going to be another question on that later, but the issue is that we present information as a sort of a semantically understood phrase. And to me, there's a level of recursion that goes beyond the word information, and it's meaning making.
Yeah.
How do you make meaning from the message that's being given to you so that you can incorporate it into your life? And we've been working on a project that you're welcome to go and look. It's on the NHS Digital stand at the moment, looking at augmented reality to support. It's really to extend the magic of the consulting room, as Amir Hannan, my GP, says. And it's this idea that unless a patient is going to respond to it, engage with it, it's pointless. Yeah. And if I can just say one more thing, I used to conspire quite frequently with the late Aidan Halligan on Well North. And he said something that I found quite profound, which is that there are two things that trump health. One is domestic violence, and the other is poverty. If you haven't got those two sorted out first, then there's no point in trying to sort out your health. And unless we start to take this holistic view of information and the way people make meaning from it, particularly in areas that are less privileged, shall we say, we're not addressing some serious issues.
Okay, thank you. So we're going to move to information analysis. And I'll go to Maureen and Keith. Under Keith's leadership of NIB, there was a thing called Strategic Clinical Reference Group, and they've put forward their requirements for clinical practice in terms of the output of Paperless 2020. One of their key attributes is you are bright people. You understand your business. Why haven't you got end-user query tools on your desk? Not so that you can start thinking innovatively about the care you have. And one of the things that it says in there is we should have, by 2020, end-user query tools that start to enable clinicians to ask questions about their patients and about their care, to self-improve. We haven't got that capacity at the moment. I think that's really important in information analysis. So Keith then first, then Maureen on the educational element of that question with its three parts.
Look, it's a really good point. I would come back to Ian's point. I mean, we've got to, as clinical leaders, say, you know, this is what we want out of our data, this is how we want to present it, etc., and work towards that around the standards and whatnot. I tell everybody, if you want to send me an email, I'm not going to scroll it down, so get all your information in the first page, because if it's beyond that, I can't handle it. What I would say, though, is just as an observation, if we were sitting here maybe 5 years ago, what we'd be saying is, come on, give us the data, we haven't got any data. Now we're saying, cripes, we've got all this data, we need to get information out of that data, and then we'll move on to where do we get knowledge out of that. So we are moving, but and the amount of data that we're getting is, as I'll tell you after lunch, is just unbelievable. So it is going to be it's a work in progress, and we just keep iteratively asking the questions, knocking on the door and provoking the answers.
Maureen, finish on this one, then we'll move on to the next question.
Yeah, so it's the needle in the haystack problem. And how do I, from all this data that you potentially can access, how do I as a GP get the data that I need to most effectively look after that patient? And the subset of data that I need as a GP is probably going to be very different from that which the oncologist has, for instance. And so we do need to get better, it's smart data, isn't it? I suspect that this is where the artificial intelligence route may well take us. So ways to tailor the data that the individual clinician, the individual patient needs to solve the problem or to give them the information they need at the particular time when it's relevant and most effective. It's also a safety issue. Too much data is as bad as no data from a patient safety perspective.
Thank you. Sir, over there, next question, drive on.
Thanks very much. Dave Rowland's Strategic Clinical Network. I think first just a word of thanks. I wasn't sure what to expect today. I thought it'd be very techy, but it's all been very patient and clinical focused, so thanks for that. I appreciate that. I understand it. Great. So my question, which will come as no surprise following the last session we're in, relates to information governance and lack of understanding of, and the blockers sometimes in terms of how we move forward with digital information. Because, like Joe was saying, I think it's going to be very key to the flows of information to the patient, to primary or secondary care, flows between primary care and secondary care and back, flows between secondary care and tertiary care in terms of MDT working, and in terms of clinical management, when we talk about strategic networks, and how that communication is enhanced. I raised some issues, and a lot of people raised some issues in that meeting in terms of how information governance, there's a culture of fear really in the NHS of getting it wrong, and so the answer usually is no when we try to do something which involves communicating in different forms of IT which are available now. So I suppose my plea is to say, how do we go forward in terms of learning, in terms of possibly a central repository, so that we do use that do once and share philosophy of the NHS, rather than all having to go through a lot of barriers, a lot of blocks, and then actually leap forward. So is there a potential that we can, especially with the new GDPR coming through, I'm not sure I got the acronym right, but that we all don't go through this process of no, it's not possible, it's an information governance issue. And I've learned more after the meeting in terms of the art of the possible, which is already happening from others that are already doing these things, whereas I know in my own locality the answer's been no. no, no, no. And so can we have a central repository, please, and do some learning so we can disseminate this?
Yep. So we had just to give the panel a bit of a flavour on this. It's quite good. We were asked the question: a patient wants their information and wants it emailed to them. They understand that they aren't on nhs.net. They understand they're not on a secure, but they want the letter. The clinician is more than happy to give them it. The clinician's being told no. As far as I'm concerned, the patient's consented, they've given affirmative action, they've understand the risks, and they want it, we should give them it. And that's the end of it. And I got feedback that this was a profound step forward in information governance, which I thought was a sort of ordinary position. So what's happening is there isn't a knowledge base of the art of the possible out there. So that's where the questions come from. So information governance as an enabler, i.e. you can't do it this way, but you can do it this way, or this way. Panel, who would like to start? Keith and then Maureen.
David, look, great question, and this whole thing does my head in that we have overcomplicated it unbelievably. So I have part of my team who run data and information governance sitting down with people like Martin to produce the handbook, you know, the idiot's guide to IG, to say you can do this, you can do this, you cannot do this, you cannot do this. Try and make it as black and white as possible and take as much of that grey out of it, because wherever there's grey, the answer is no, because people who are making decisions will always default to the risk. So we are actually doing exactly that.
Maureen and Ian?
So information governance is hugely important. Of course it is. It's essential for public confidence and public trust. But information governance is not the trump card. Patient safety trumps information governance in my book every time. Public safety trumps information governance. Patient consent trumps information governance. Yep. And I think poor chief execs and boards have been so beaten up about information governance that they think that's the trump card, and it's not. So there has to be an element of get real, actually. And there has to be, you know, we have to have the conversation with the public. If we, as users of the NHS, want the maximum benefit from our systems, if we want the most effective patient care, there is an element of trade-off. We have to have information governance processes. We have to take it seriously. It's important, but it's not the be-all and end-all. And I think we really have to move the conversation into that space, because so many times, you know, things you want to do, things that seem to be a good move, we can't do that. And we've got to move away from that, in my view.
Ian? Couldn't agree more. We need some core principles here that don't get hung up on the technical and management issues of governance. There are important cultural changes required in information governance. I had three core principles here. That our governance to best serve patients and the public needs to be proportionate in terms of benefit and risk. Patients are harmed every day because of undue specious concerns about information governance that are leading to a lack of data sharing and patient harm. So, proportionate, participatory. In a world of increasingly connected data and more things you can do with data, you can't govern every anticipated use because you can't anticipate all the uses. This is moving very fast. But you can reveal back to patients what was the journey of your data, what was done with your data. You show someone what's happening with their personal data. And progressive, that would be my other P. We build the governance for where we want to be, not what we've got now.
Okay. Thank you.
Martin, can I just say...
Yeah, just say anything you like.
Two things, picking up on Ian's point. One is the last time I looked, nobody ever died of breach of confidentiality, but lots of people have died because we haven't shared data effectively. And I'd much rather be up in front of the ICO than the coroner, thanks very much.
Yeah, me too.
Okay, next question.
Dr. Amir Hanan, I'm a full-time GP. I'm also the chair of the Association of Greater Manchester LMCs. I'm the co-chair of the NHS Values Group and the chairman of the World Health Innovation Summit. And I just want to share a story with you and then ask a question. One of my patients presented to the GP surgery with a lump in his testicle. He was seen by one of my colleagues and referred for an ultrasound scan. He then rang up the surgery to find out the result of his scan, and that was the conversation that I had with him. During the consultation, I asked him if he had the internet or if he had an email address, and he said, no, I don't have that. So I said, okay, well, you've been diagnosed with an epididymal cyst. At that point, he turned around and said, can you spell that for me, please, doc? And I said, why? And so, because I'm going to Google it. And I go, oh, right, so you do have access to the internet? Well, yes, I do. And I said, okay, well then, let's go through a consent process that takes 2 minutes, which I was able to do over the telephone, so that he can have full access to his full GP record. The problem title has epididymal cyst in it, so if he wants to read how to spell it, he can do. But there's an information button next to it that links back to trusted information where he can learn stuff rather than Google searching and getting himself into a tiz. And then most importantly, during that shared decision-making that took place within the consultation, I've written down the history, the plan of action, what we've agreed, so that not only can he read it after he's put the telephone down, but so that he can then share it with his wife, his family, and he can start to make decisions about how best to plan it. Now that's the story. My question is, how much information do you think we should share with patients? And I'd love to hear from each of the panel members what you feel we should do, and secondly, what you want for yourselves.
Okay, so Joe, do you want to start with that one? Because
I mean, I think my response would be we would need to think very carefully about it being proportionate. So if I think of some of the people who use mental health services, too much information arguably could be a really tricky issue for people to absorb, yet others, I think we should be pushing, and I mean pushing, as much knowledge towards them as possible. I think how I'd try and construct the answer is, what would I be doing it for? Is it engagement with that person to react to their need, or is it engagement to get more understanding between the organisation and the individual, or the clinician and the individual? And I think that might help me decide which way I'd want to go. So I'm not ducking the answer, I just think it's phenomenally complicated, but a good question.
David, you should go next.
There are 3 actors in this. There's the patient, and the way the NHS is currently resourced, we've got to enable the patient to become far more proactive in their own healthcare. There's the doctor, and unless that doctor, for me, has established a partnership of trust, and I know that information is being provided to me in a way that is relevant, to get back to meaning making, is a way that I can make meaning to make those decisions. And then the third actor is the information itself. And I said I was fortunate in being able to access all my records. Perhaps the biggest stroke of fortune is that my doctor doesn't use any jargon, uses plain English, doesn't use any abbreviations, and is ready to talk about anything that I want to go back to clarify. Usually by phone, that's sufficient. So I think those are the key elements for me, but the absolute priority is that environment, that partnership of trust that enables those 3 actors to effectively work together.
So Jane, what do you want to see in your record, or if you want to see your record?
So if it was my personal view, is I'd like to see everything. I'd like to have access to everything. And in fact, I have got access to, to vast majority, I think, unless there's stuff I don't know about. But the point in response to Ami's question, there was also, I don't think there's a straight answer. My initial impression is that it should be as much as the individual patient wants, but that should be a discussion and a proper. So it should be a discussion with the clinician, and I would say this is bigger than or wider than just doctors. So this should be the responsible clinician, who could be a dentist, a doctor, a nurse, an AHP, It will depend on the individual circumstances, and that should be part of a discussion that is had with an understanding about what people have access to and why they might want it and how that can be best done. So it has to be person-centred decision, not a blanket one-size-fits-all.
Right, I know you asked the question for everybody, and I apologise for that, but I've got 5 minutes, and I want to go really quickly with short questions. So I appreciate comments, but I just want questions, right, that we can go through. And there's a gentleman there, then a gentleman here, and I've got 5 minutes, so go. Come.
Hi, I'm Kishan. I'm a consultant psychiatrist in Greater Manchester Mental Health Trust. We recently had a change in electronic patient recording system. My main question is, how do we ensure that any information technology requirements or data inputting requirements don't eat into the face-to-face clinical time with the patient?
Okay, that question, it's about technology interfering with the relationship. I'll go to Joe because he's got mental health units, and I'm going to go to Maureen. Okay, go.
Yeah, just a massive problem. Totally agree. We've got to have really serious conversations from my perspective with you guys, something we've been doing in my own trust. But I think more importantly, we need to understand what it is we're looking to get out the back end of all of this. And then you can work out whether all of the stuff you put in the front end of it is meaningful or completely lacks meaning. It's not that complicated, but you need to go through those steps, I think.
Okay.
So interesting as a GP, we never had any data entry requirements, okay? We just had systems that we used for our records. And I think GPs would resist to the hilt any obligation for data entry requirements. So basically, you need to be able to have whatever you need in terms of data fit in the clinical workflow. If it doesn't fit in the clinical workflow, what are you asking it for? Yeah. And we as GPs over years have had to learn to record and consult at the same time. It's technique, it's a way of taking your profession forward. And I now type as fast as I write, probably faster. And that's just how we work in the modern age. And actually, I would think that most of certainly colleagues, certainly millennials, barely use a pen. They're using their thumbs, aren't they? So I don't think that's going to be as much of a problem for them. But it's just we need to work in different ways.
So education, general practice led the way, taught each other how to interact with the technology for the best results with patients, and we need to do it across the platforms. Sir.
I'll try to be quick. Rob Alcock, I'm CCIO from Gateshead. Picking up on Maureen's question earlier on when you said, why is it we have so many fax machines? And I think it links to what Keith was saying, because of this sense that if there's greyness, the default is no. We have the fax machines. Everyone in this room knows we have fax machines because for too long, the message was, don't use email unless it's nhs.net. And we, 18 months ago, wrote specifically to the ICO to ask them to give us a hierarchy of IG risk, put them in order. Where does fax fit in the spectrum compared to using email that isn't nhs.net? Because that's the real world. And they refused to answer. So my question to you, Keith, is how soon can you produce your document that just answers black and white questions about sensible stuff that everybody agrees we should do, but we need somebody at the centre with influence to reassure our board?
How soon? It's imminent, so it's being put together now. So next few months we would hope to have at least a first draft out. And we'll iterate it, we'll make it a dynamic process. So if there are questions that come in, we can say, no, boom, and use it like a wiki thing.
That will be hugely useful.
Right, I've got 1 minute. Anybody, a 1 minute, a 1 minute question, and then they're going to get up and they're going to leave, okay? So where's the mic? They're up there, right. Lady, great.
One question regarding information governance. One of my patients asked for the results of our investigations. I was wondering how much I could give the results directly to her and how much she would be able to understand. So I suggested we will forward it to the GP. but the patient wanted directly, then I came to know she was consulting privately as well, and she wanted to take all those investigations to give to the private sector. As part of information governance, I do not know how much information directly you can send it through email. I forwarded it towards the information governance and that route. Later on, she complained of the delay in getting all her results. Please.
So this is, I'll take this one. This is direct care. You have to make a clinical decision. You are qualified as a clinician, you're registered and regulated, you have to make a clinical decision. Is this person going to accept these results? What will she do? I've had to deal with both ends, both positive and negative. You have to make the clinical decision. I've already told you, if she consents for ordinary email, she's consented. She's made an explicit decision. You say, it's not that secure, but it's probably better than mail. Do you want it sent? She says yes. You record explicit consent to having the information by email. But you have to make a clinical decision on that dissemination to the patient. It's not an IG issue, it's a clinical decision. And I'm very happy from the learned group on the platform to disagree with me, but it's a clinical decision to share or not to share for that person.
It's a clinical decision now, but in the future, it won't be clinician plus a record. It'll be more like your health avatar in which you lodge preferences.
Yes.
There's already being a lot built at the moment about how do we use things like blockchain technologies to encode patient preferences in smart contract. In this context, share. In this context, I actually prefer, as an individual patient, not to share. This landscape is becoming more complex. I would focus, as we've said throughout this discussion, on solving the problems that exist now. And one thing that hasn't come up is what we're going to stop doing. When does the algorithm say, we just need to share to check those serial blood test results? So the clinician who keeps on checking and doesn't need to keep on checking because the algorithm's better is released to do something more important for the patient.
Right.
Progressive approach.
Thank you very much. Please show your appreciation for the panel. Thank you. You're free.